As you know, Massachusetts is sort of in everybody's, on everybody's radar screen, and what we do here makes a difference to what the rest of the country thinks. There's a lot of misinformation out there about Massachusetts, and I think the Medical Society's efforts to keep track and put information out there is really appreciated. I do want to acknowledge that there's a lot going on in Massachusetts, even though people think, well, we already did healthcare reform. We sort of did it, but there's a lot to be done. Every day, just about, I get articles sent to me from people in Massachusetts or from around the country about various opinions about Massachusetts health reform. And there are lots of, I think, misrepresentations about whether people actually got coverage, the cost of healthcare reform, and also the impact on the healthcare system, which is something I know the Medical Society is really trying to monitor and put out there so that we can understand what it is we need to do to better support physicians who want to take care of people, and healthcare reform is supposed to help them do that. Implementing healthcare reform in the midst of the recession has also, I think, created some issues because some of the things that are happening that are a direct consequence of the recession get conflated with healthcare reform. And I'll be glad when the recession goes away so we can get back to the business of really understanding how health reform is working for people, at least based on the principle that everybody has a right to health care, that we should have universal coverage, and it is our duty as a society to make sure that that happens. But even through the recession, there are some things that I want to point out about Massachusetts. I was really shocked when we did our household survey of coverage last year and found that in the fall of 2010, right in the midst of really the worst part of the recession, that we were still finding that about 98% of people had coverage, including 99.8% of kids. And when I, oh good, thank you. We should applaud that. We should be very proud of that. And part of the reason why that's true is when I thought about it, reform was really built on the premise that even if you don't have employer-based insurance, you should have access to some kind of health insurance. And in fact, in analysis that we've done, we've seen that the fastest growing population in Mass Health has actually been the long-term unemployed. It's the first time that they actually took over the growth of kids coming into the program as the fastest growing population. That said, I want to get back to the fact that we've got 99.8% of kids covered in Massachusetts. That means that we have about 3,300 kids out there who don't have insurance, and our goal is to try to identify them and get them all. One of the other myths about healthcare reform is that it busts the Massachusetts budget. Well, prior to the recession, as we looked at what was needed to invest in the implementation of healthcare reform, what we found is it really accounted for less than 1% of spending on the state budget. So that's hardly a budget buster. It's a pretty modest investment for what I think we've been able to achieve. But again, because the Mass Health budget has become such a big part of the overall budget, and that's for two reasons. Number one, members are growing. We've added over 260,000 people since the recession. And number two, the overall state budget has shrunk. So that's why Mass Health is a larger part of the budget. The other thing that I want to talk about with you, because I know that this is a grave concern for you and it's something that you've been working on, is the the fact that even though people have insurance, they don't always feel like they have access to care. The study that you put out 3 weeks ago, looking at some of the factors related to access, certainly highlights that. And in the work that we've been doing to kind of track not only the number of people or the percentage who are insured, but we are trying to look at the impact of healthcare reform, there are a couple of things that I want to point out. Number one, 92% of people report on the last survey we did in 2010 that they have a regular provider. This is an increase from 87% prior to reform. And one of the things that's, I think, telling about that number is that we actually see the greatest increase among Hispanics and blacks in Massachusetts, where the increase in the percent who have a regular provider has increased significantly. One of the other things that we know based on the recent analysis that we did of primary care physicians in Massachusetts, which is reported in a November 2010 report that the Division of Healthcare Finance and Policy put out, is that 50% of new licenses that the Board of Registration is issuing is going to primary care specialties. Now, part of the question is, well, what's the rate of people leaving the profession because of retirement or for whatever? But I think that this is one of the first times that they've seen that represents such a large percentage. The other thing that we know is that the absolute number of primary care physicians has actually increased every year since 2003. So part of the difficulty here is when you're only reporting numbers, things seem like they should be pretty good. But we know that the way to really improve access is that we need to support doctors and other providers in a much better way so that they're actually able to take care of people. One of the things that we implemented last November is the Patient-Centered Medical Home Initiative. There are 50 practices across Massachusetts who are participating in this initiative. It is a multi-payer initiative, so almost every commercial payer in Massachusetts is participating. They're not participating at exactly the level in terms of financial that we had anticipated when we started talking about the project, but it is a multi-payer initiative. And this project does two things. Number one, it helps the primary care practices that have been selected transform the way they practice and the practice design toward a patient-centered medical home. But we're also testing a new payment model that acknowledges if you want primary care providers to work in teams, you have to pay them in order to have those team members. But it also acknowledges that the types of things that we're expecting in terms of better care coordination, better transitions of care from one clinical setting to another, also takes resources. And so we're testing a payment model that recognizes that and explicitly paying practices for that. I want to say a little bit about payment reform. I want to thank Alice Coombs and Linda Young actually for meeting with me many, many times, but Linda also has been participating in a work group that we convene and meet every 2 weeks. So she's been fantastic. I think she's been to more meetings than I have. To ultimately better support providers in their practice so that we are paying doctors to take care of people, which is what I keep telling the governor should be our goal. It's not about whether we have 15-minute appointments or half-hour appointments or we're paying for X procedure or Y procedure. It's really that we want to say to doctors, do what you need to do to take care of people, and we want to support you in that. Now, that's a pretty generic goal there, but we do think that reforming the payment system is the way to get there. We recognize that this approach in terms of payment reform is not a one-size-fits-all. I've heard Alice and Linda say that many times. We recognize that. We do not believe that hospitals should be the center of the universe of ACOs. There may be some hospitals who are the central figures in ACOs around Massachusetts, but we envision a wide range of diversity of integrated providers, ranging from groups of primary care practices in communities, perhaps working with a community hospital, to the ones that I'm sure that you all can imagine. We are putting out requests for information either next week or the week after, where we're going to invite people to tell us, what's your vision of integrated care? What should it look like? And how should the state, through its ability to put out regulations or lead the way or whatever you want to call it, how can we support that? And how should the payment system support the type of integrated care that you have in mind? So I'm going to invite you to look for that and to respond. I'm sure I'll get an official response from Mass Medical Society, but we want to hear from the diverse groups of doctors who are in the state. The reason this is important is, and I will acknowledge that the regulations that CMS put out for ACOs were pretty surprising to me, all 400 pages of them. That's not what we envisioned. And we have, I think that we have a challenge in getting the federal government to understand that if they put those types of regulations out and those types of restrictions on what, for Medicare purposes, they will call an ACO, it's going to hamstring us all in being innovative and being able to create entities in the states, in Massachusetts, that represent a much more diverse entity, I think, than what they envisioned. But the reason it is important for us to hear from you about this particular issue is because we're going to take the feedback we get from this request for information and develop a series of demonstrations in Massachusetts where we can actually implement payment methodologies that are consistent with what we will hear from this process, that will look at different models for implementing different payment methodologies, whether it's global payments or bundles or whatever. And we want to be able to build those demonstrations based on the information we get. So I invite you to participate. We look forward to hearing from you, and I think I've used my 10 minutes.